Hello, everybody. Good morning, good afternoon, good evening, and thank you very much for joining this important webinar hosted by the International Diabetes Federation on access to insulin in humanitarian emergencies. My name is Philippa Bull, and I'm a non-communicable diseases advisor at Médecins Sans Frontières, or Doctors Without Borders, based in Geneva, Switzerland. I'm really honored to be moderating a fantastic panel of speakers today who all have experience in this important topic that is firstly key to the work that I do daily, but more importantly, that can be really a life or death issue for those requiring life-saving insulin and simultaneously caught up in one of the very many humanitarian crises that affect the world today. Recent crises have brought some much needed attention to this issue of insulin access in emergencies, but there's still a lot of work to do to make insulin access specifically and diabetes care more generally more readily available in crisis settings. Today, we'll hear from some of those working hard on this topic, but we'd also like to hear from you. So please make sure you put your questions and comments in the Q&A so that we can discuss them during the panel discussion. A few quick housekeeping points. Please note that the webinar will be recorded. If you need subtitles, these can be activated by clicking on the closed caption button at the bottom of the Zoom window. But as these are Zoom activated subtitles, please be aware that they may not be completely accurate. People often ask for slides from these webinars, and don't worry, they will be sent to all of you who have registered in a few days' time, along with the link to the recording and a feedback questionnaire. And all of you who attend live will also receive an attendance certificate. Lastly, as already mentioned, we really want your participation, so please do use the Q&A function to contribute your questions and comments. In case you missed it, this is a follow-up webinar to the Insulin Be Prepared event from last year, and you can find the recording of that online, and you'll find this YouTube link in the slides that you will receive in a few days. So that's enough from me. Let's start. We're going to have a number of panelists presenting shortly today, and that will be followed by a panel discussion during which we'll try to address your questions. To set the scene, we're going to hear from the President of the International Diabetes Federation, Professor Akhtar Hussain.
Thank you, Dr. Philippa. I'm sorry that I cannot be with you in person today. I have work commitments here in Norway. My name is Akhtar Hussain. I'm a professor at Nord University of Norway in the field of diabetes and metabolic syndrome. At the International Diabetes Federation's General Assembly in Lisbon in 2022, I became the president of IDF. First of all, I would like to thank all the speakers volunteering their time to support IDF activities. Secondly, I would like to thank all attendees for your interest for joining us today. Today, we address an important theme. As we know that every year, millions of people are affected by natural and human-caused disasters. The tragic event that have recently unfolded on the border of Syria and Turkey are a stark reminder of the devastating effect that impact of a disaster can have. They present a significant threat to lives and bring disruption to health services and the availability of food and water supplies. Some emergencies grab the headlines, while the others do not receive the same level of attention. As we all know, people living with diabetes require ongoing access to care, education, medication to manage their condition, and in many cases, the associated complications. For people living with type 1 diabetes, disruption to the supply of insulin, as well as devices needed to deliver insulin and monitor its use, presents a potential threat to life if not addressed immediately. People living with type 2 diabetes are also equally affected, since many of them depend on insulin or other medications to manage their condition. It is key for the government and healthcare system to have a disaster plan in place and to know where they can turn for support in case of any humanitarian crisis. Diabetes representative organizations have an important role to play in preparing and for responding to disasters. Today's panel of expert speakers will share their example and further describe the implication of disaster for people living with diabetes. Let me close my brief introduction by wishing you all a very successful webinar. We look forward to seeing you at the future IDF events. Thank you.
Thank you, Professor Hussain, for those important words. So let's move to our panelists. First, we have Dr. Alicia Clark, who is Director of Pharmacy and Clinical Affairs at Direct Relief. She will be speaking on protocol after an emergency is reported and donations from pharma. Thank you, Dr. Clark.
Thank you so much for the opportunity. It's really an honor to be here on this panel to speak with all of you on this really important topic. So really appreciate the time. So I'm Alicia Clark. I'm Director of Pharmacy and Clinical Affairs at Direct Relief. And I'll provide just a brief background of our organization, how we mobilize resources during disasters and emergencies, and why collaborations are such an important role in our response. Next slide, please. So just a brief background, we are a global humanitarian medical organization. We were founded in 1948 post-World War II, and our headquarters is here in Santa Barbara, California in the States. We really focus on providing charitable donations of prescription medications and other medical supplies, really to treat the most vulnerable and underserved patients around the world. And we do this on an ongoing basis and also during disasters. And I'll come back to this point. I think it's important. And our mission statement is really to improve the health and lives of people affected by poverty or emergencies without regard to politics, religion, or ability to pay. Next slide, please. It's just a little snapshot on our distribution center here in Santa Barbara. It's 155,000 square feet. You can see on the floor there on the left a bunch of pallets. We have 10,000 pallet spaces available. And in the middle picture there, that is our walk-in cold chain space, walk-in refrigerator, 2 to 8 degrees Celsius. And this was expanded during COVID, just recognizing that a lot of the pharmaceutical companies were producing medications that require cold chain, including insulin, vaccines, rare disease medications. And so we decided to expand the space, just anticipating a growth in that space. Last year, we did 27,000 shipments, so pretty high volume, 3,000 of this cold chain. So we've learned a lot along the way. And it's 5 million pounds of product, equivalent to about 2 billion wholesale value for distribution. And we support all 50 states, US states and territories, as well as over 100 countries. And so just wanted to pause here and talk about our emergency response, because I think that that support is really the foundation of how we're able to act so quickly. So just speaking to how we run through a disaster, we have an emergency response team that's always on high alert. They're registered for different alerts. So once they receive a notification that there has been a disaster, if it's like an earthquake or if we see it coming like a hurricane, we have all of our existing kind of facilities that we regularly ship to mapped out. And we use that map to identify who in the area could be affected. Once we draw that radius, we do outreach to those groups and ask if they need any assistance, as well as give them access to the inventory that's in our warehouse. And so there's a lot of communication that happens. What are the most urgent needs? Do you have power? And it's really important if we're going to be shipping something like insulin, just to make sure that they have power to be able to store it. There's also, the transportation issue. Are the roads open? Are the airports open? We work really closely with FedEx, as I have that picture there on the right. They're our strong logistics partners, so they're able to really tell us what airports are going to open first, what distribution centers are going to be open, how the roads are looking. So they're really helpful during emergencies and disasters. So once we get a request back from somebody that we've reached out to, we can start picking and packing that product pretty much immediately. We only send product that is specifically requested for a disaster. We don't send anything else. We don't want to clog up the lines for things that are not necessary. So our shipments are really curated to the needs of what's happening on the ground. And how fast we can do that, it really just depends. There's a lot of different factors. It depends on where it's going. You know, in California, we're able to drive insulin to certain facilities. We drove insulin to a shelter during a wildfire within the same day. So we can work really quickly within California. Internationally, there's a lot of different factors that play a role in how fast we're able to act. So customs clearance, if we have a waiver, transportation, communication, all of that plays a role. And the one thing that we do think about is, you know, if we can't know all of the needs at the same time. And so if there's products that we have available, we're able to ship them and move really quickly. If we don't have them available, we can reach out to our pharmaceutical donors. So next slide, please. Just a quick snapshot of some of the donors that we work with. Relevant for this conversation, you'll see Eli Lilly, Novo Nordisk, and Sanofi for their insulin products. Also BD and Invecta for needles and syringes. We also work with LifeScan for our meters and strips. So we're really thankful to these companies who are really responsive. If there are additional needs during disasters, we can reach out to them and ask for specific products. Next slide, please. These are a few of the associations partnerships that we have, and we're really, really thankful for them, just because we're a relatively small team here at Direct Relief, about 100 people, and so it's hard to have our eyes and ears everywhere, and we're also not experts on disease states, and so we really rely on organizations like IDF to help kind of guide us during emergencies, to have more touch points, have bigger picture of what's happening. And so we rely really heavily on these professional associations to help be our eyes and ears and to provide some guidance as well. So we're very grateful for that. And I'll stop there.
Great. Thank you so much, Dr. Clark, and amazing to see the supplies you've been able to mobilize. And I think an important message early in this webinar about the importance and power of partnerships in addressing this issue and being able to mobilize insulin, but also associated supplies. So thank you. On another note, just to say we have over 400 of you who've joined from all over the world. It's fantastic to see all these different countries popping up. Please do participate, put your questions in the Q&A so we can try and ask them during the panel discussion. And moving now to our next speaker, Dr. Amulya Reddy, and she will speak to us about gathering civil society for a better response. Dr. Reddy is the advocacy co-lead at the International Alliance for Diabetes Action and is also an NCD, a non-communicable diseases advisor for MSF based in London. Thanks, Dr. Reddy.
Thank you, Philippa, and thank you to IDF for the opportunity to speak on behalf of IATA. It's a real privilege, and thank you to all the attendees. I also will go ahead and thank the chair of IATA, Dr. Sylvia Kalenbrink, for the slides that I'm going to show, and to talk to you a bit about the background and how IATA came to be and what we are in the process of working on now. Next slide, please. I just have a few to go through quickly for the background and how IATA came into existence. So I think the previous webinar reviewed the issues of poor insulin availability and affordability in the low and middle income countries. Next slide, please. And then of insulin storage where refrigeration is not available. And this can actually be a limiting factor to people accessing treatment. Next slide, please. Diagnostics are equally lacking in many of the settings where they're most needed. Next slide, please. And then clinical management with health systems that have been focusing on infectious disease burden and not necessarily on chronic disease. There's a huge shift that's been needed and has started. Next slide, please. And then we have to keep in mind how chronically underfunded non-communicable diseases are in general. So this, including diabetes, has been an area that we really do need to focus more attention on. Next slide, please. So IADA, the International Alliance for Diabetes Action, is a partnership of international organizations that came together in 2019 after a symposium that reviewed these problems that we've just highlighted, and developed a Boston Declaration with some objectives to address them. The mission is to ensure vulnerable people in humanitarian crises have access to quality diabetes care and to prevent unnecessary disability and death of people living in these settings, and also trying to deal with their diabetes. The Boston Declaration has been updated with the most recent event that we had in Krakow, Poland, in just a few months ago. So the link is there for that. We go to the next slide, please. To describe the work a bit further, 4 work streams were established. The first for medicine and diagnostics to improve access, with a focus on insulin, knowing the significant issue there with availability and affordability. And also, however, to highlight the need for the accompanying diagnostics and cardiovascular risk reduction medications that are needed in order to continue diabetes care appropriately. The second work stream is about clinical and operational guidance in trying to ensure that there are evidence-based guidelines that are adapted for crisis settings. The third work stream is on data and research, knowing that there is a lack of quality data across the board, and that can help guide decisions and plan programs. And then finally, advocacy, policy, and financing work stream, which, although everything is about advocacy with the other work streams, this is intended to focus a bit more on the trying to promote the financing and policy aspects that can support the human rights of people living with diabetes, and to help mobilize resources. Next slide, please. The working streams, as you can see, come together around the person living with diabetes in a humanitarian setting. So keeping them in mind, the different work streams are interacting in different ways. The medicines and diagnostics with regulatory bodies and supply and logistics agencies and specialists, as well as with industry, directly with pharmaceutical companies, and with other procurement agencies. Clinical and operational, the clinical and operational work stream is in part functioning through coordination with the UNHCR informal working group for non-communicable diseases. So that's helped anchor some of the work in trying to provide better guidelines and improve operations and planning. And then for data and research, that this is gathering some of the academic organizations are involved in IADA, and linking them to implementation teams and monitoring and evaluation teams for better information sharing and dissemination. There are also a couple of platforms that have been set up to promote that as well, one through LSHTM, and then also directly through the IADA website. And finally, for the advocacy, policy, and financing, we've linked up with academics and economists and donors and funders to work on the needed policy and financing aspects to ensure diabetes care in humanitarian settings. Next slide, please. So in conclusion, what IADA is aiming for through this gathering of over 60 organizations and partners from different sectors is to ensure that insulin is included in the humanitarian response and available at primary care level, that it's affordable, and that it's included in a package that includes the delivery devices and the monitoring that is needed. And then to ensure that guidelines are available and feasible to implement and incorporate some of the recent learnings on insulin thermostability and storage that some of the partner organizations have developed. And then also to ensure that, again, the clinical management progresses in terms of being able to adapt and ensure that that not only staff but patient self-management and education and support can occur and be provided in humanitarian settings. Next slide, please. I'll stop there. Thank you. So this is the IATA website, and thank you.
Great. Thank you so much, Dr. Reddy. Again, really great to see the ability of different actors to come together and identify key pillars of work to try and harmonize the efforts around this work that's needed. And also thanks for really pointing out the person living with diabetes at the center of that work. Moving on now to Dr. Irina Vlasenko, Vice President of the International Diabetes Federation. Always a pleasure to see you, Dr. Vlasenko, and thank you for talking to us about civil society response during the Ukraine crisis.
Thank you so much. First of all, thank you very much for our who enjoy for this meeting. It's very important topic. Maybe you little bit take something from us, but in same times, it's very good platform for discussion. And I hope we can teach from each other. Next, please. I many times spoke about our war. Unfortunately, 1 year soon will be war in Ukraine. And if I write like beginning of the war, almost half of the pharmacies did not work. Hospitals were destroyed. Many medical workers were either moved or unable to work, but this is not only beginning, that continue now in same situation in many regions, continue because Russia bombing us every day and many people dead. I even not spoke about soldier. This is a terrible situation because it's extremely influence on we speak about people with diabetes, because for us it's very important, because without insulin we cannot continue to live. That's all. And next, please. And what we find, some gaps of, I told many times how we start work, and we see many gaps on action in the Ukrainian war. It's lack of coordination, lack of communication, and problem with logistic. We cannot deliver some region because bombing, and unavailable diabetes care and pharmaceutical provision. Next, please. You see the situation. And I would like to say many, many thanks to my colleagues from all over the world who motivate me and like push me, because it's very important. I was in shock during first day, and then everybody called me, and we tried to collaborate, and I try to use my position as in IDF for help in our people with diabetes, and try to action and IDF Europe. I say exactly about IDF Europe. Of course, it's part of our big communication and a big part of IDF, but this is big input from IDF Europe. And we try to, based on communication, partnership, and management. If you see, I put only few points like who work with us. It's minister, and of course, from beginning, I start work with Ministry of Health, because only Ministry of Health can deliver humanitarian help to some region. And it's a lot of help from WHO, pharma. Also, I can say that direct relief, Alicia, thank you so much. I suppose that we improve our communication. It was luck from on beginning, but now I'm soon will be meeting our, and also pharmaceutical company give to us supply and insulin directly. This is also big input. And of course, government from another country like Norway is right to them, and they send a lot through the European Union, and big input IDF member association, another patient organization, professional organization, and others. As we see before, my colleagues report about this input. To be honest, I was very happy with these guidelines, which they prepare very quickly how shift insulin and includes insulin Ukrainian product. It's helped not only for Ukraine, but also for refugees. But it was what I can underline, that it was in time. This is very, very important. And that it's a big, I think it's helped to us very much. And our doctor in another country. And next, please. And direct relief and member association, humanitarian help to Ukraine. Thanks again to direct relief, because you see, thank you, Elisa, that you present how it's big and how it's work. Because without you, maybe it's not possible. Without your partnership, it's not possible to deliver this help. And we send a lot of pharmaceutical company and another company to support, to send money to you organization for organizing this humanitarian help. Because we have not possible even go out. We have not, as I say, you cannot say buy anything outside and broke everything, but thanks God, your support and many and other people, also individual, I want to underline. And we, from beginning, we organized Connect Solidarity. This is IDF quickly organized a special platform where we put information for refugees. This is also very important, because must be that not, of course, you can find some diabetic association in Poland or in Czechia, but it's very important that some people exactly will be responsible for this. This is, and we did this. It's work very much, and I listen a lot of tell story that is a great help. And what direct relief, they not only provide supply and insulin, and also provide financial support, grant to member association, to our one of association in Ukraine, and also one of Poland, because mostly refugees move to Poland, and Poland give to us extremely big support. Thanks a lot. And next, please. And this is
I'll just ask you to wrap up fairly soon, if you don't mind.
Yeah, so that's all. You see, big civil society input, I have already told. And next, please. Medical collapse in occupied territory. It's now, it continue. What it was 1 year ago, and now continue. Next. What this is important, the medical mobile team in reoccupied territory that go to different organizations. Sometimes this is like support government, but sometimes it's only initiative, some Red Cross and other from Israel Association. Next, please. And situation in Ukraine now with reimbursement. Maybe I told about this later. Next. And now we have plan for future. This is European. This also helped to us European Parliament declaration now, resolution. Sorry. Now, and I was in meeting in this ministry, and I think we collected now needs, and also I have meeting with some organization and association and also groups, and we collected needs, and soon we'll be meeting with also with direct relief and IDF. Thank you very much for your attention.
Thank you so much, Dr. Vlasenko, and thank you for highlighting the challenges that you faced in this situation, but also I know that you have been very instrumental in trying to support the needs of people living with diabetes, and you pointed out the importance of kind of personal connection, support and partnership in that regard, and the importance of timely support, which I think is also a good reminder to us all responding to emergencies. Thank you.
Yeah, I also I also people with diabetes. Yeah, I
Yes,
know.
and absolutely. So you bring that double hat, and you very important in your testimony. So thank you. But we'll have more opportunity to chat in the panel. So we're going to move now to Dr. Lancy Larco from the Haitian Diabetes and Cardiovascular Disease Foundation, and she will present on living with diabetes in Haiti.
So good morning, everyone, and I'm thanking IDF for inviting me and Fatima to participate in that panel. So I'm the Executive Director of FADIMAC, and next slide, please. So I've been asked to talk on the living with diabetes in Haiti, and I mostly focus on the problems that our patients are facing with the insulin, the availability. So Haiti and its challenges, we are prone to natural disasters. Hurricane season is shown there from May to November, earthquake, flood, unfortunately, but also we do have man-made disaster. And we have been for many years in constant political instability, civil unrest and protests, and abstinence of governance. We have the killing of our president, and insecurity is really at its max now with kidnappings and violence. And I think it's like war but we have nobody to fight with, and it's very difficult to live, and mostly for our patient, because the results of all that, we have the patient mobility restriction, and also our patients are unable to access to care and receive their medication. So it leads to life-threatening and even fatal issue. Next slide, please. And other challenges we've added to it, it's infrastructure absence, and we have almost no electricity, sometimes not even 1 hour per day. So we have to rely on generators. And so the health institutions must invest heavily in to keep the cold chain. So due to the mismanagement of the state, the emergency crisis is worsened, and the oil products are sold on the black market, which makes the cold chain even more difficult and costly to maintain. And we are facing also on counterfeit insulin, unfortunately, and we have had fatal conclusion, with our patient using those insulin. So we have, we put our patient where we ask them to recognize the good insulin. So that's something that we are dealing with. And you should know that most patients in Haiti, they are most patients on insulin, they are self-paid. So only 4% of the population is covered by an insurance. So we are trying at FADIMAC to really help those patients, and thanks to our supporters. Next slide, please. So as providers, and I forgot to put Lily, I'm very sorry about it, because they are the one giving to Life for a Child insulin for our kids and young adults, and also insulin for life, and Novo Nordisk, the providers in Haiti for insulin. And the transportation is mostly done for us by direct relief or another local provider. And so that's something that really is appreciated. And we storage for, at custom, there are difficulties. Everywhere there are difficulties, but we are trying to fight with it. And corruption, so it's really, we have to deal with it and to make sure that we receive the insulin enough fast. As the custom, they don't have cold rooms. And at FADIMAC, our cold chain cost us, and thanks to direct relief, who are helping us to put something on so we can really be helpful for our population. So for patients who don't have electricity, we ask them to put their insulin in clay pots. So next slide, please. And this is what we are, a civil society. We have been on the field for more than 35 years, and we are giving health services, national advocacy, and mass awareness. And also we train physicians and providers, and we have an MOU with the Ministry of Health so we can help them in those matters. Next slide, please. And that's the award that FADIMAC received in last December in Lisbon. And thank you to IDF for giving it to us. we were really very happy to see that even in we are trying to do, and it has been recognized internationally, and it gives us strength to continue. And this is the last slide, is about our outreach program, where we tried really to contact the health centers so they can be helpful for their patients. And so when we go to a place, we do awareness screening, medical clinics, education of the patients and their family, training for the health centers, and also distribution of insulin. Some places they don't have it at all. And medicine also for diabetes and cardiovascular disease. We do advocacy, and also we follow up with those health centers that we are working with, and we are doing virtual meetings so to give our knowledge to the far health centers where we can be helpful. So thank you and I'll be available for the question in the panel.
Thank you, Dr. Lacko, for this really interesting presentation, and fantastic to see the comprehensive response that your organization is providing. I think for me, you highlighted really well this challenge of the need for cold chain with insulin, both for transport and storage, but then some practical solutions with the use of clay pots during the use of patients, by patients. But clearly, I think there's a need for some clear guidance on this moving forward, knowing that there's increasing information coming out about the thermostability of insulin. Thanks very much. So moving on to our last speaker, last but not least, we'll hear from Professor Solomon Tesfaye, who is the Research Director of Diabetes and Endocrinology at Sheffield Teaching Hospitals and the University of Sheffield, and he'll talk to us about living with diabetes through the Tigray crisis. Thank you, Dr. Tesfaye.
Thank you very much, Philip. Good afternoon or evening or morning, wherever you are in the world. It really is a great opportunity to talk to you about the Tigray crisis. I'm originally from Tigray. I came to England when I was 17 years old, many years ago, trained in the United Kingdom, and I'm a diabetologist in Sheffield. And so in this very brief 5-minute presentation, I'll try and cover this terrible crisis in Tigray. I'm also the founder and honorary president of SHARE, Sheffield Health Action Resource for Ethiopia, which has been really working to help with diabetes care, not only in Tigray, but also in Addis Ababa. We've had many trips to educate on how to manage diabetes. And next slide. And we've trained many doctors, and one such doctor who's going to be the center of this presentation is Dr. Merhawit Atzbaha, who is from Tigray, from Mekelle. And she attended a course here in Sheffield, and she was an incredible, highly rated doctor, the only endocrinologist to serve 7 million people in Tigray. Next slide, please. Just to tell you where Tigray is, Tigray has 7 million population. It's in North Africa, and is bordered by Eritrea, Sudan on the west, and Ethiopia. It's part of northern Ethiopia. That's in the northern part of Ethiopia. And unfortunately, a war erupted on the 4th of November 2020. And the Eritrean army from the north, the Ethiopian army from the south, including militia, invaded Tigray and occupied Western Tigray, that you can see displacing around millions of people because of ethnic cleansing to Tigray, and also a lot of refugees, around 70,000 refugees still in Sudan. And this war has been the worst humanitarian crisis in the world, with around over 500,000 deaths. In fact, the African Union, represented by Olusegun Obasanjo, former Nigerian president, said 600,000 people have died in this terrible war. But the world doesn't know about this. The world knows rightly about Ukraine, about the disasters in the rest of the world, including the terrible situation in Turkey with earthquakes, but nobody knew about this. And we need to ask why. And this war was characterized by terrible sexual violence, rape of women and girls. And we don't know the extent of this, but obviously it's going to be in tens of thousands, about 2.4 internally displaced people. And the region was cut off from banking, communication, electricity, and people not being paid at all for 2 years. And this humanitarian blockade, because essentially Tigray was encircled and there's no way out and no aid was coming in. Or if aid was coming in, it was trickling in. It was a deliberate effect. And this also was characterized by massive destruction of the infrastructure. And the MSF actually reported that 70% of all these health facilities were looted and 87% were not functional. MSF worked initially in Ethiopia, in Tigray, but then was unfortunately kicked out. And so next slide, please. And so you can see to diabetes care, just immediately after when the war erupted, there was absolutely no insulin. And you can see to the diabetes services and laboratory tests were completely halted. As you can see, very, very minimal service. Next slide, please. And this is the hospital, IDA Hospital, and we've collaborated with IDA Hospital as well as other hospitals in Ethiopia, as I mentioned. And Dr. Merhawit works in this hospital. And she then wrote a letter to the IDF, and this was published in the journal, in the IDF journal, which was, and I want to read it to you because it was a harrowing letter. As one of two doctors responsible for the management of diabetes at IDA Referral Hospital, I would like to highlight the plight of people with diabetes, particularly those with type 1, who are now at serious risk of death due to lack of insulin. In Tigray as a whole, although an underestimate due to underdiagnosis, there are around 6,726 patients with type 1 diabetes and around 17,006 to 7 with type 2 diabetes receiving regular follow-ups in the hospital before November 2020. Since July 2021, we've not received any diabetes medicines from the federal government, despite continuing to serve greater numbers of people with diabetes with more acute needs. We exhausted our stock, etc., etc. Essentially, there was absolutely no insulin. The little insulin that was there was being used as an emergency to manage DKA. Next slide, please. And a report recently derived also that from the pharmacy also, they were left with 150 vials at this point. A catastrophe was unfolding because, as we all know, type 1 diabetes can only be managed with insulin. In conflicts, there are always many wrongs, often from both sides. But we feel denying medical care to innocent civilians under any circumstances is unethical. We appeal to healthcare professionals around the world, the International Diabetes Federation, the UN, the African Union, to help avert this blockage of critically important life-saving medicines. And so this was a letter that was published, and it went on the social media, and Professor Andrew Bolton, who was the former president of the IDF, was instrumental in really publicizing this. Next slide, please. And this led to a letter, a publication by The Guardian, which is a newspaper in the UK, and which really highlighted the issue and the dire situation unfolding and people dying. And then within a week, thankfully, ICRC flight carrying medical supplies reached Tigray. But this was a drop in the ocean, but soon afterwards, the situation deteriorated. Again, we were faced with no insulin for months. And oncologists were crying because of lack of cancer patients just dying needlessly. Next slide. Dialysis patients, all dialysis patients died because they couldn't get, and this could simply have been transported very easily by ICRC flights. And this is really sad. Next slide, please. HIV patients, and you can see thousands had no treatment. Hypertensive patients dying of stroke because they couldn't get any medications because of this total blockage. And no oncology services are mentioned. Next slide, please. Now, a peace treaty has been signed on the 2nd of November, and some aid is getting through. Some medicines and also have also started, insulin has started to come a little bit, but only to serve around 5% of the population. There is a dire shortage. The health infrastructure is completely decimated. It needs to be rebuilt. It needs a lot of help from the rest of the world. The Ethiopian government seems to be in good, wanting to now honor this peace treaty. We want international community to support this and also to provide with badly needed insulin. Next slide, it's my last slide. I want to finish with this, really, alone we can do so little, together we can do so much. And I think we have this pharmaceutical industry, the IDF, civic society, politicians, the world, if we come up together, we can act quickly to avert such terrible situations as in Tigray. Thank you, Philippa.
Thank you so much, Professor Tesfaye. Really difficult to see the real challenge, the real consequences, devastating consequences of the lack of access to medication in these situations. But finishing on a really important note there of the importance and potential of collaboration to prevent these things happening in the future. So thank you. So on that somber note, we're going to move on to our roundtable. So I'll ask our panelists to please turn on their cameras, and we're going to go through a number of questions that you've been asking. But just to start off, we might just do a quick update on each of the specific contexts that we've heard from today, and perhaps again just to continue with you, Dr. Tesfaye, if you can just give us a quick update as of today, what the situation is for the people living with type 1 with diabetes in Tigray.
Sorry, I think there's an echo. Can you hear me okay?
We can, yes.
Okay, Philippa. So your question is, what the situation in Tigray
today? Just to get an update on today.
It's still very, very poor. I managed to speak with the head of the services in Mekelle at the hospital. Insulin is terribly short in supply. Laboratory services are non-existent. We're raising some money to send some money to help with this. Sorry, there is an echo.
There is. I was going to say yes. I'm not sure.
I don't know whether it's coming from me or.
I think so. I don't believe if some of the IDF people can confirm. I don't think anyone else has their microphones on. So.
Anyway, let somebody else talk
sure,
while I try.
Sure. Perhaps Dr. Vlasenko, just a quick update on the situation for people living with diabetes in Ukraine today.
Oh, this is depends of region, of course. If region little bit better situation, not bombing every day, it's we have insulin. Mostly we have insulin. But we have also reimbursement system work. But now I listen many problem that this is of course the system function. But what is main challenge now that people far away, for example, in many region, town, city, well not city, village, have not a pharmacy who has this reimbursement system. In this case, people must go to another region, or not another region, to big city and get insulin. First of all, this is very difficult, dangerous, and the additional money. Now it's like this main change. We must change this situation, but now we have some people. I didn't hear that people change insulin. Sorry. Most even someone tell me that he changed insulin for better insulin. For example, he dreaming about another insulin. And also, government provide some now test strips for adult. Maybe not for everybody because, but anyway, there's somebody got 10 package, and also was problem with insulin if you need delivery, and also prescribing. This is also difficult if it's not doctor. We have lack of doctor who can prescribe this insulin, and they start to family doctor. Family doctor not very happy with this because it's another case. This is system. You can say system work, but finally it's not work. We must improve this situation. And I want to underline big input stress, because stress, our dose increase. Many people, I listen, this is from beginning, but it's continue because it's big influence on stress. But like this. But of course, if it's occupied territory, I told you that it's collapse. And medical, I spoke with ministry. We are afraid that we will have many complications, because 2 years before COVID, and now I have not access to care to prevention some complication. This is very important. We must check this. We must focus on this also. Like this.
Thanks, Dr. Vlasenko. So yeah, still a very challenging situation. Great to hear that strips are being provided, even if not enough. And I think this is something that can often be overlooked, that insulin may be provided, but strips and also injecting supplies can be missed.
Not everybody, but anyway.
It's yes, well, definitely something we need to highlight more. And you mentioned also the impact of stress. I think there was actually a question on that in the Q&A, and certainly that's something that I think I saw in your mobile clinics, that you had a psychologist in the mobile team. So important to recognize that and try and co-manage that as well.
But our refugees who have very big terrible situation, for example, dialysis on something like need treatment, which you have not possible, they go to another country, and they thank God for this country.
That's great to hear. Yeah, thank you, Dr. Vlasenko. Professor Tesfaye, do you want to try again?
Yeah. Yes, it's better now. Sorry, I was double, so that was the echoes coming from there. So currently, at the moment, laboratory services are almost non-existent. So they need reagents, new. So this is one of the problems. Strips, we don't have any. A little bit of insulin for hospital use for emergency is there, but really patients from around Mekelle, the capital, there are a lot of type 1 patients supported by the Life of a Child for many years. Insulin supply has not been very good, but need some more insulin. And so that's the other thing we need. We need insulin maybe to, how do we work? What sort of channels do we have is very important. I think we need to communicate with the Ethiopian Diabetes Association, which has been very useful. They've always supported that insulin should reach every person in Ethiopia. So perhaps working with them and also communicating directly with the doctors in Mekelle, in the capital, the endocrinologist, Dr. Merhawi Tatsbaha, and others, to ask what the need situation is. And no, I mean, the situation is terrible, and no ambulances, everything is been completely demolished. It needs rebuilding, but at least there's an interim measure. What are the things that need to be supplied? The IDF should have a channel of communicating with each country, if possible, particularly those disaster areas. Direct channels with the doctors, communicate with the doctors, with the health needs, what's needed, and then communicate with the diabetes associations. And so that this life-saving medicine should be available for everybody. So I'll stop there, but perhaps I'll add into other topics. Thank you.
Thanks, Dr. Tesfaye, and absolutely the importance of clear channels of and established channels of communication, and hearing directly from clinicians and diabetes associations on the ground regarding the needs. Dr. Lako, we wanted to get an update on the situation as well for people living with diabetes in Haiti. And there was a question from the audience also, just trying to understand if there are some key places where patients can find insulin in the crisis period if they were to run out of it. Did we lose? I think we've lost. Did we lose Dr. Lako? Okay, so perhaps we'll move on for the moment. Dr. Clark, there has been a question in the chat about the response to the latest earthquake in Syria and Turkey. I wonder if you could give us an update on that.
Sure. Yeah. I mean, I think it's still unfolding. You know, the initial phases were really focused on looking for survivors, and so we you know, have partners that are on the ground already, the Syrian American Medical Association, and also, you know, some of the critical care societies and search and rescue. And so the initial kind of response was primarily funding, with a commitment to be able to move fast and provide resources for people that are on the ground right now doing those search and rescues, doing critical care management, nephrology services. There are a lot of crush injuries which require, you know, dialysis emergently. And so I think that phase is, you know, unfortunately coming to an end as far as the kind of acute needs of our search and rescue. And it's going to go more into kind of longer term needs, chronic disease management, as a lot of the infrastructure has been damaged. So we have about 14 shipments now, either packed, ready to go, or have already arrived in both Turkey and Syria with chronic disease medications, as well as, you know, IV fluids and some of the more acute stuff. But in there, you know, our diabetes medications, type 2 oral medications right now is really the bulk of it. And then we are working with IDF just to understand what the needs are on the ground for insulin specifically. We've been connected with the Syrian Diabetes Association. So we'll just continue to work with the manufacturers at, you know, putting in requests on behalf of the people that need the medications.
Great. It's great to hear that. I think, you know, historically, the needs of continuity of medication have not been at the forefront of responses to crises. So although it's early days, good to know that this is already being thought of and already planned. So thank you for that. Dr. Lako, back to you. We wanted to just get an update on the situation for people living with diabetes in Haiti, and specifically to answer the audience question on whether there are key places where people living with diabetes are able to find insulin in crisis. You're just on mute. If you could unmute, thanks.
Thank you. So I am speaking mostly for Fadimac, but we are in Port-au-Prince, Haiti, the capital, and we work with affiliated centers so we can provide them insulin and medical material that we receive in donation. But I should say it's very difficult for people outside of the cities to find their medication. For the oral part, as the Ministry of Health has decided that glibenclamide, metformin, and insulin are essential medicines, but it's only the pill that they can find. And sometimes it's expensive for them. So they take it for a while, they stop and they go back. So you can imagine the complication that they come with to the health centers. And unfortunately, mostly they are not diagnosed. For the insulin, that's a very heavy problem because when we do our outreach program, and you see people coming, they should be placed on insulin and they are just receiving pills. One is because some physicians are reluctant to put patients on insulin. So we give them the appropriate training so they can do so. And secondly, because of the availability to bring the insulin. So as you can see around the world, let's say the insulin should cost like between $3 and $10 US. So sometime outside of the cities, they pay more than $50 US. So it means that it's heavy for them, really heavy. So we should say that when we talk to the health center, so that's why we are telling them, you can keep the insulin outside of the fridge because you don't have electricity. Instead of thinking that it's not possible to use it, we can save patients with that. So, and also because they don't have access to the insulin, so sometimes they buy any kind of insulin. And I was mentioning about the counterfeit. That's a big problem in Haiti. And as you know, 70-30 or NPH, they are supposed to be cloudy. So we found bottles of 70-30 with clear water. So that's something that is unacceptable. Even if we talk to the Ministry of Health, they're trying to do their best, but our patient is not out of problem with that. That's very difficult, really.
Yeah, you've highlighted a number of really big challenges there. One of the ones you mentioned is this challenge that certainly we see of clinicians on the ground not necessarily being the ones comfortable managing diabetes, and great to hear that you've implemented some training to try and support them to do that. Dr. Reddy, I wanted to jump to you on that point just to see from your experience working with MSF, do you think that the right guidance exists to support clinicians needing to manage diabetes in emergency settings?
I think we do have guidance, but it still takes that step of bridging the and imparting the knowledge, the training, and the support that staff need on the job to become comfortable with taking on a new approach, the chronic care management and the complicated disease that diabetes can be. Unfortunately, it's difficult to manage in any country, and then trying to learn very quickly in a crisis situation can be difficult. So I think we do have simplified guidelines in terms of trying to narrow down the choices of the potentially the most effective and feasible to implement medications, and then but the staff do still need a lot of support. And then again, ensuring that staff also learn how to support patients in enabling the self-management that patients need to do, or people living with diabetes need to do, because they need to take care of themselves most of the time outside the clinic. That's what's important.
And I guess even more important in an emergency when access to healthcare can be really tenuous. So, yeah.
Yes.
Great. So, Dr. Clark, back to you. There's a question about this understanding what is the important or what is the necessary medication in critical areas after a disaster strike. So how do you get this information? And then the challenge of actually accessing, getting the medication where it needs to be. So how do you manage the delivery if there are blockages in the roads, the air, in getting to where people are in need of insulin?
Yeah, I think it's complex as far as understanding what the urgent needs are. We rely heavily on what the situation is on the ground and people that are experiencing the disaster. So even though power can, go out intermittently, we still get needs lists from different providers, and they can vary quite a bit depending on what their focus is. So we do look at those needs lists extensively and kind of compare it to our inventory and try to match it basically as closely as possible, so they don't have a big sorting project when things arrive. So we want to be accurate. We want to provide high quality medications directly from the manufacturer. And then as far as the logistics challenges, I think we've just learned a lot. So I think working with FedEx has been really helpful, just because we're able to access some areas that are not readily accessible by commercial means, working with different freight forwarders, partners on the ground that can clear customs. So there's different techniques that our transportation department can utilize, and different resources to be able to get it to that last mile to the patients in need. So I think every situation is different. It has unique challenges, but we've with the history of responding to different types of disasters, whether it be earthquakes or hurricanes, floods, tornadoes, we've learned a lot along the way, and we can start to anticipate some of the needs that are going to be coming the way. With chronic disease, always is, oncology needs always come after kind of that acute phase. And so we can anticipate that, and we try to respond, to those needs.
Thanks very much. Moving to you, Professor Tesfaye, whilst you were presenting, there was a comment in the chat, why have we not heard about the Tigray emergency? And I think we all know that some humanitarian emergencies get more visibility than others. I wonder if you have any thoughts on why this might be the case, and how we might be able to help all humanitarian emergencies to get similar visibility.
I think that's a very good question, and somewhat controversial. But I mean, the WHO president himself said the only reason that these situations are missed could be, he used the word, the color of skin. It is controversial, but I think actually there is some truth in it. I think that the things that happen in Europe have a much bigger visibility, partly also because there are reporters. Often reporters have been banned from Tigray for the duration of the war. The government didn't allow any reporters at all. Internet services were down, everything was closed. It was systematically sort of, the people were just isolated. But there were some brave people, and some people actually, the Guardian in the UK, certainly, Lizzie Davis, others, Kana from APS. There have been other reporters, the BBC has been reporting a lot, but it never hit the mainstream media. It actually never hit the 9 p.m., in the UK, we have a sort of, it used to be the 9 o'clock news, but now it's the 10 o'clock news. It never hit that. And that's always shocked me. And that's despite writing letters to the BBC to highlight the problem, the plight of the people. It's not about siding with one side or the other. I'm only interested about the humanitarian situation. The people in the middle are lacking food and dying because of lack of food. How do 500,000 people, because of direct killings, massacres, drone attacks, and starvation, death, and also a lack of medicine leading to death. How does the world not see this? If you actually look for it, it's there. If you search the internet, it's full of those. If you go on the Twitter, you'll find it. But actually, it doesn't. I don't know why. It's complex. I don't know why it hasn't hit. The area is not a rich area. It's not important. It doesn't have any oil in it. It is not of importance to the. But nevertheless, these are people. These are people. It's an ancient civilization, and these people dying in these numbers, and nobody bats an eyelid. That really saddens me, and partly because I come from there. And I was not able to talk to my family there for 2 years because there's no communication was blocked until the peace treaty has been useful. The guns are all silent now, and there is some aid getting through, but it is woefully inadequate. There is absolutely, and why is that? I mean, everything should be open now. Everything should be flowing. And I think direct communication is very, very important. I'm digressing a little bit, but I think investigators need to go. Just because you're banned from entering a situation, we used to have amazing people going, but the problem here is you cannot report from Tigray. You're not allowed, but that should be debated. Now in the UN, it's blocked constantly by Russia and by China. Blocked these. Because then the UN becomes a completely useless apparatus to avert the situation and to be looked into. The African Union, to be fair, has done something. The United States has been engaged recently. So a peace process has started. Let's hope this leads to sustainable peace and leads to improvement in the dire humanitarian situation.
Absolutely. So a clear message on putting politics and colour of skin aside and remembering the absolute imperative for access to medical care for all those caught in conflict and crisis situations. Amulya, Professor Tesfaye mentioned the words of WHO at the beginning, and I wanted to see if you could give us some thoughts on the role of WHO in emergency preparedness for diabetes in the emergency response.
WHO has been quite active, and we really appreciate the efforts to include humanitarian situations in their NCD work, and specifically to highlight diabetes through the Global Diabetes Compact and the Global Diabetes Compact Forum that involves people living with diabetes. And throughout all of this, they have included humanitarian organizations and considered the settings. So they have developed the NCD kit to be as an addition to the emergency health kit 10,000 that we've all been using for many years. With that, I think there's still some work to do in terms of ensuring that, again, people understand what's in the kit and how to use it. There has been some guidance, but I think there's been some difficulty in actually utilizing what's sent out and implementing that. So ensuring that people are aware that those kits are available and they're able to acquire them, so they incorporate those in their preparedness plans, but then also planning on training staff to be able to use what's in the kit and anticipating that as well. And then the other work that they've been doing on trying to organize supply for NCDs at assisting ministries of health or at national program level. We have had discussions on including humanitarian situations in that as well. So to be able to calculate some extra capacity when thinking about these needs and on a longer timeline, if the ministries of health are thinking about a 5-year timeline for NCD medication supply, at least incorporating, from year to year, some extra for potential humanitarian situations, I think would be quite helpful, and they have been looking into that.
Thanks, very useful. So I want to ask a question, I think, to each of you, but if we could, unfortunately, we're running out of time because this is such a useful discussion. So I'll just ask you to answer very briefly in a few words so that we have time for a few more questions. In your experience, what would you say is the biggest challenge that people living with diabetes face in humanitarian emergencies? Nancy, if we could start with you, please.
Sorry, can you repeat? I didn't hear it well. Sorry.
Sure. Can you hear me?
Yes.
We just wanted to know from your experience, what is the biggest challenge that people living with diabetes face in humanitarian emergencies?
I think the biggest thing is the ignorance of the disease of diabetes, because a lot of patients, they don't know what to do. And there is no preparedness for those patients when something like that happens. And secondly, to be recognized by their government, as a population who needs help. Because in those situations, if they don't get help, they die. So we, in Haiti, we experienced that. So I think it's the reconnection of what diabetes is and what can be done fastly for them to survive.
Thank you, Nancy. Irina, a few words from you.
I think I would like to say many, but of course, if we have not insulin, we cannot continue to speak about anything. But if we, lack of medicine, this is main things. It must be improve logistic and storage, but I want to say that must be better collaboration between government and NGO and our association, patients group. This is very important. They know exactly what people need, and they have view specific on these people with diabetes. And this is our organization is very important. And my experience, and I try to develop this subject, education, because we are not prepared for this in education. This is possible. I also don't know before, but now I try to develop some documents for pharmacists, and we have also for the Federation, Pharmaceutical Federation, because sometimes only pharmacists affordable for available for people with diabetes, like healthcare provider, but also education people with diabetes. They must be prepared. They must know what nobody can care, for example. They must know what will they do. They will.
Thank you, Irina. Absolutely. And I think that's been brought up a few times, the importance of people living with diabetes being educated and empowered. Alicia.
Yeah, I think the challenge is it's really multifactorial. It's not just one solution. It's, access to the insulin and the medications, but also the supplies, access to cold chain facilities to maintain the integrity of the product, power to back up the cold chain storage. So I think it's just a lot of different factors. It's very complicated. And then during these big, emergencies, their insulin gets, if it's in short supply, there are also other patients that are non-diabetic that might need the the insulin as well. So, in ICU settings, we work with the Society of Critical Care Medicine, and they set the guidelines to set blood glucose levels for ICU patients that aren't diabetic. So there are some resources that get put into, the most critical patients. And then if there's already a short supply, then that further exacerbates it. So I think, again, there's a lot of different factors and a lot of different complicating things like nutrition as well for refugees. And I think it's important to address all of them.
Thanks, Alicia. Solomon. You're on mute. You're on mute.
Okay. I agree with Alicia. I think we need to have affordability and access to insulin, particularly in poorer countries, developing countries. The International Insulin Foundation, of which I was a member for many years, until a couple of years ago, I was secretary, does work with many countries to try and have a line of how insulin can be accessed to particularly the poor people who can't afford insulin. So that needs to be strengthened. IDF needs to be, insulin is now being produced en masse around the world. Why can't people get bottles of insulin, people that can't afford it? This needs to be really thought around, and maybe industry collaboration. They can make their profits in developed countries. In the poorer countries, they should be able to give insulin, life-saving medicine. So access and affordability is number one. Number two, if you have reasonable amount of access in times of trouble, then you have that capacity to stay alive for a couple of months. At least you have some medicine. The problem in Tigray was that everything vanished so quickly because people were using just small amounts of insulin, 3-4 units of insulin injecting to stay alive with blood sugars of 20-25, just to stay alive. And that is shocking when the world is full of insulin. And these should go into the conscience of these Novo Nordisk and others that need to really have, support insulin availability, affordability in the world. The second thing is we need to have this, it's not just the fact that it is available, it's actually there is a line of communication that this insulin can be then dispatched and reach the people quickly, and that needs internal communication. The societies, the associations, international associations, they need to work with individual countries to make sure this network or availability of insulin can be improved in times of emergency. Because without insulin, people die. So that's the most important. There are other needs for oral agents, etc., but this is probably the highest priority. Thank you.
Thank you, Solomon. Indeed, insulin is a life or death issue. Amulia, instead of answering that question, I'm going to move to another one. Alicia, I think, touched on the issue of nutrition, and it's been brought up in the chat as well. We know that access to healthy food and exercise can be difficult or if not impossible during a humanitarian emergency. But of course, we know that many emergencies these days become protracted crises. And so just a few thoughts from you on how these challenges around food and exercise can impact people living with diabetes in the long term.
I think as we know, taking these measures contribute to glycemic control, which we need in order to prevent complications. So when people are unable to do these aspects of self-management in terms of managing their diet and continuing some physical activity, then they are at higher risk for complications. And I think ICRC has certainly reported on the increased number of complications and amputations that they have been involved with in settings where people have not been able to continue proper diabetes care and have been subject to complications. This is yet another area that we need to address in terms of we do often forget, and I think we have started trying to discuss some options for improving nutrition and paying attention to this area. But it's certainly, again, in some places, we need to take a lifestyle approach, actually, which may sound unfeasible or not feasible at all for the crisis situation, but it will have multiple benefits and tie together various interventions. So.
Thanks, Aurelia. Indeed, challenging to address, but in protracted crisis, really important to try and do so. Nancy, I'd like to come back to you and to the role of civil society organisations and just to get your thoughts on the role that diabetes associations or other civil society organisations can play when it comes to ensuring access to insulin and diabetes supplies in humanitarian settings.
Okay, unfortunately, there is no coordination between the Ministry of Health and the different organizations. Of course, they work together, but myself being in the part of metabolic disease and diabetes, I don't feel the engagement of none of them in the diabetes part. So insulin is available, can be available, as we are the hub of Life for a Child and Direct Relief. So we are able to send insulin to our affiliated center. But when you get to even though that FADIMAC have signed an MOU with the Ministry of Health, and you tell that to those big organizations, and as they have their own agenda, we don't feel being part of it. And that's a pity, because civil society is a power, and we are the one on the field, and we are the one working with the people. So I feel there is a gap between the work of the civil society and the Ministry of Health with their partners. So I hope that some of them who are hearing what I'm saying, that they get to the civil society, because even when I get to them, and I don't need to say exactly who they are, because they are the big people there, and they say that as your Ministry of Health doesn't ask, so we can't do anything with you. And I don't think that's right. So I hope that this webinar with all the panelists, what they have said, and I hope that all those ideas and concepts and feelings are getting to those big organizations here, so things can be changed and less hypocrisy being done.
Thank you, Nancy. So a strong message. Let's bridge the gap between civil society organizations, ministries of health, and other responders. Thank you for that. Alicia, there have been lots of comments in the chat about Direct Relief and the support that they've provided to different emergencies. So Direct Relief, I believe, is a member of the IDF. Would you be able to just explain very briefly how the IDF Direct Relief collaboration works?
Yeah, just really briefly. So IDF and Direct Relief developed and implemented the Global Diabetes Partnership in 2019. And really the purpose was to raise awareness around access issues and really provide an opportunity for the pharmaceutical industries to provide donations of products. And so, luckily we've been able to secure donations of insulin and medications and supplies through the partnership. And distribute those, to multiple countries. So I think just raising the awareness has been a really important part of the relationship, and also the collaboration, as well as the collaboration done during disasters as well.
Irina, a final question for you before we wrap up. We just wanted to understand from you the role of people living with diabetes and civil society organizations in the neighboring countries to Ukraine and the response.
We are very happy with them. They help to us very, very much. And not only our organization, like IDF member, neighbors company, not only members country. I put my picture, like to Polish association, send Australia Diabetes Association help to Ukrainian refugees. This is amazing family. This is we feel in this. This is very important for us. And this is also big, show big role our community, how we can do together, how we communicate together and improve our communication. This also need, and also with direct relief. I think we will do this. And also I want to underline big role our member association who in Ukraine, also in neighbors country who help to our people. But also we, of course, maybe I focus on my country. This is very next to my heart. But Solomon, Professor Solomon, I also was a little bit involved and also tried to help through the WHO to this problem when we start listening about this. But also this is big problem. We must work hard. We have big space for improve our collaboration and have good results.
Thank you, Irina. Unfortunately, we're running out of time, so I'm going to ask a last question to each of the panelists, and I'll ask you to please just keep your responses brief and explain in 30 seconds. What would you ask from governments to improve emergency preparedness and to make sure people living with diabetes are looked after during humanitarian crisis? Solomon, would you like to start?
Yes, I think each government has responsibility for its own citizens. And civic society is important to empowering people. Diabetes UK in the United Kingdom does amazing work. And it's not just the center in London, Diabetes UK headquarters. It is in Sheffield, we have a Diabetes UK patients group. They identify key gaps in key needs that the government needs to look at, and they highlight this. They communicate with their members of parliament. So empowering the citizens, so diabetic people, is very important in each country, and that's because they are the ones that vote for people. So they are the ones then the government then will react to that. Otherwise, relying on the Ministry of and the governments to do the thing is, unfortunately, in many countries, not going to happen. It's got to be driven by the actual people, the stakeholders themselves, the families of the people. And also the IDF has a major responsibility to ensure there is a flow of insulin. So it's multifactorial. I'm going to stop there because...
Thank you. So indeed, not just governments, but everyone else as well. Nancy, some thoughts from you, please.
As Professor Solomon has said, the Ministry of Health, they have their responsibility, but I think also that the civil society must have the same power and work with all the stakeholders to make availability for medicine and for care. And I should say, especially for Haiti, where it's very difficult to go around. So as in the award that we received, we showed that we should have taken helicopters and plane to go in other places in Haiti instead of using the roads. But it takes money, and civil society, if they don't have a support, they can't do it. So that's a pledge for helping really to support the civil society, and of course, working with the Ministry of Health, who would have a lot of lack of resources, that we can work together and with the help of the stakeholders.
Thank you, Nancy. Your thoughts, Amulia?
I second everything that's said, but for government specifically, I would ask them to ensure establishment of diabetes programs with the adequate funding to ensure training of staff and supplies so that the capacity is there to take on any crisis in a complementary fashion, even if humanitarian agencies are intervening, to ensure equity across populations. Thanks.
Great, very important. The role of the importance of having pre-existing services to be able to cope with the crisis. Alicia.
Yeah, thank you. I think just echoing what others have said as well, and also recognizing that the needs during disasters are highlighted, but really the gaps exist in non-emergency settings, and really to focus efforts on, closing those gaps so that they're not worsened in disasters, just spending our energy and efforts to highlight access on a regular basis.
Thanks, Alicia. And Irina, we have 1 minute left for your final words and my wrap up, so please.
I will not repeat I will, because it's a lot of great idea which I support, and I only want to say that together we can do more. Together we can achieve more. And this is maybe sometimes very difficult find way to collaborate, but we must. That's all.
Thank you, Irina. And in fact, I don't need to add much to that because my last words were going to be on how the importance of collaboration has been really clear through this webinar to address the multifactorial challenges, putting people living with diabetes at the center of the response, ensuring that everyone has access to healthcare, making sure this problem is recognized, and making sure that insulin is affordable even to those who can't afford it. So thanks so much to all the panelists for this fantastic session and for all your insights. We have, I think, some really important lessons from this and a lot of work to do together. I hope all of you will stay engaged. Thanks for all of you on the chat. It's been a super interesting chat. I wish I'd been able to keep up with it during this, and lots of questions. So we appreciate that and hope everyone stays engaged on this important topic. Just a few housekeeping points, I think, to conclude, if you don't mind moving to the next slide. Just a reminder that all of the recording, the slides, and a feedback questionnaire will be sent to you. Please do respond to the feedback questionnaire. It'll help IDF to improve future events. And please don't hesitate to send any questions that you have to the email address that's on the slide. Thank you very much. And thanks once again to our panelists.
Thank you, Philippa, for your moderation. Very active moderation.
Thanks.
It was a pleasure.
Excellent.
Thanks, Philippa.
Thank you all. Thank you.
Brilliant.
Bye.
Thank you.
Thank you.